Good afternoon. We begin with our first case. The history provided was 66-year nulliparous female with primary amenorrhea. She had bilateral breast lump for 3 years with sudden increase in left breast mass with ulceration of overlying skin. On examination, bilateral inguinal mass were noted. MRI chest revealed a 15.4 by 11.5 centimeter lobulated large heterogeneous mass in the left breast. MRI abdomen and pelvis showed a soft tissue density in soft tissue mass near the deep inguinal ring. There was a blind ending vaginal tract, and uterus and ovaries were not visualized. We received specimen of left MRM, right lumpectomy. The left MRM specimen measured 32 by 20 by 15 centimeter. The skin showed an ulceration. On cut section, the tumor showed a variegated appearance, grayish white solid areas with areas of hemorrhage and necrosis. Right lumpectomy measured 15 by 10 by 5 centimeter. Cut section, it was solid gray white. Left inguinal mass measured 5 by 3 by 3 centimeter. The cut section was lobular with yellowish areas and few foci of hemorrhage. The right inguinal mass was 5 by 3 by 2 centimeter. Cut surface showed small yellowish lobules with a central white glistening areas. The scan sections were provided from the left MRM and from the right inguinal mass. 10 slides from scan slide sections have been displayed here from the MRM and 8 from the inguinal mass. I would like to call upon the representative from Tata Memorial Hospital, Dr. Ayushi, to discuss the case. First, we will be discussing left MRM. Yes.
Yeah. Thank you, Dr. Ashwini. Am I audible?
Yes, ma'am.
Yeah. So we received two sections from the left MRM and one from the inguinal mass. And in this slide, we can see that the section from the left MRM basically showed a fibroepithelial neoplasm with compressed slit-like epithelial component, which is benign, and in between the stromal cellularity was markedly increased. They were, you can see that the stroma is arranged in the form of fascicles, and increased cellularity was noted. Next slide. There were areas of hemorrhage and necrosis. Next slide. Again, I think areas of necrosis being shown here, and uh, they were again the tumor cells with the spindle cells, the stroma showed with a myxoid background. Next slide. And on higher part, you can see that the spindle cells they were in a myxoid background. Though the pleomorphism was not much, cellularity was markedly increased. There was definite stromal overgrowth, and in one of the sections, the edges of the tumor seemed to be infiltrative, and there were areas of the frequent mitotic activity was noted, which in some of the sections was at least 2 to 3 per hyper field. Overall, it seemed that it could be more than 10 in 10 hyper field. There was no other differentiation or heterologous elements seen. These are again areas of increased cellularity, areas of hemorrhage, and with a lot of increased cellularity. Next slide. And these are the benign epithelial components. Some of them showed leaf-like architecture, and with the both ductal epithelial as well as myoepithelial cells at the periphery of the epithelial component. And this is the hyper view of the benign ductular component, benign epithelial component with surrounding increased stroma. Increased mitotic activity was seen. Again, moderate pleomorphism, increased mitotic activity, and hypercellular areas.
Ma'am, we will be discussing the right inguinal mass with 8 slides.
Sure. Yeah, so in this section from the right inguinal mass, we could see a tumor with a very pink appearance, with focal fibrous septa in between. The tumor cells were arranged in sheets and nests. Next. The tumor cells arranged in sheets with the fibrous tissue at the periphery and dilated vascular channels. Next. At the periphery of the section, we could see a lot of fibrovascular tissue, some smooth muscle, and some nests of tumor cells with a bland eosinophilic appearance, and some tubular structures. Next. This is from the tumor, in which we could see again the same sheets of tumor cells at places having a yellowish brown lipidized, yellowish brown pigment, and scant fibrous septa. Some of the septa showed some little bit of lymphocytic infiltrate. Next. And again at the periphery, we were seeing some tubular structures which seem to be looking like atrophic seminiferous tubules with surrounding fibrosis. No spermatogenesis was identified, and the tubules seem to be composed only of Sertoli cells. Next. These are the hyper view of the tubules, atrophic tubules without any spermatogenesis and presence of only Sertoli cells. And in between these tubules, there were those nests of eosinophilic cells that appeared like interstitial Leydig cells. And closer view of the tumor, you can see that it's composed of polygonal cells with abundant foamy to eosinophilic ring cytoplasm and uniform round nuclei. On closer view, we can see that some of the cells had binucleate and multinucleate cell nuclei as well, and the cytoplasm is eosinophilic and foamy with round, regular, uniform nuclei with distinct nuclei. Closer view again showing the round, the foaminess of the cytoplasm, eosinophilic cytoplasm, and round uniform nuclei. Some of the cells are binucleate with distinct nuclei. No significant mitotic activity was identified. So, taking everything together, it looked like a tumor arising in an atrophic testicular tissue, which, as you said, was in the inguinal region. So, undescended atrophic testes with a tumor arising in it, in a history of a 66-year-old female with nulliparous with amenorrhea. Was suggestive of a history of a presence of pseudo hermaphrodite person with bilateral undescended testes. And although the most common tumors associated with undescended test is a germ cell tumor, on this morphology, taking everything together, we thought it was a sex cord stromal tumor with a morphology suggestive of a Leydig cell tumor. We ran the immunohistochemical marker for calretinine, inhibin, and A1A3. Calretinine was diffusely and strongly positive in these tumor cells from the inguinal mass. Inhibin and A1A3 were focally positive. So it was for the inguinal mass, our diagnosis was of a sex cord stromal tumor, that is a Leydig cell tumor, and the patient also had associated malignant Phyllodes tumor, which we saw in the left MRM sections.
Thank you, ma'am. Thank you for such a good description. Any other opinion of the house? If any comments, you'll have to unmute the mic, please.
AIS associated syndromic tumor.
Can you please repeat? Can you please repeat?
AIS associated syndromic tumor.
Thank you. Thank you. Thank you. So I will quickly discuss the case. We also ran few IHCs. CD34 was positive for the breast mass. And inhibin in our case, it showed almost diffuse positivity for the inguinal mass. This is the clinical picture of the patient, a 66-year-old nulliparous female with primary amenorrhea, bilateral breast lump, and inguinal mass for 5 years. There was an increase in the left breast lump over 3 months. So on radiology, there was no uterus visualized and no ovaries visualized. So a karyotyping was done. The karyotyping revealed 46XY with a female phenotype and a male genotype. Her hormonal studies were done which showed testosterone, DHEA, which is a weak androgen, in a normal range. AMH again was in a normal range. LH was in normal range. FSH was little reduced. So with the histological picture, the karyotyping, the clinical images, and the radiological images, we came to a diagnosis of malignant phylloides of the left breast with the benign phylloides of the right breast and Leydig cell hyperplasia of bilateral testis. The case of complete androgen insensitivity syndrome with female phenotype and a male genotype. Presently, the patient is receiving radiotherapy for benign phylloids of the right breast. So this is a final diagnosis. It is malignant phylloides of the left breast with benign phylloides of the right breast with Leydig cell hyperplasia. Since it was bilateral, we considered Leydig cell hyperplasia more. It was in duration of 5 years that patient had this inguinal mass. And a complete androgen insensitivity syndrome with female phenotype and a male genotype.
With the just one this thing query that since even though it was bilateral Leydig would be rare, but on this side on the gross images also there was a proper tumor mass being formed that was composed only of Leydig cells, and at the periphery where they were benign seminiferous tubule, the Leydig cells were intermixed. There was a hyperplasia, but they were intermixed with the tubule. With the seminiferous tubule, but in this sections, the tumor was composed of only Leydig cells only, sheets of Leydig cells. So why not a Leydig cell tumor?
Ma'am, actually, Leydig cell tumor is more of unilateral than bilateral, and bilateral reported cases are very rare. Since this patient complained of bilateral mass for 5 years in inguinal region, it goes more of in favor of hyperplasia, and that explains why she developed into gynecomastia and then benign phylloids and malignant phylloids. Plus, there is no definitive IHC which can differentiate between the Leydig cell hyperplasia and Leydig cell tumor, though orchidectomy is the only treatment modality. And there was no abnormal mitosis, no necrosis, no atypical cells noted.
And that would not be required for Leydig cell tumor, atypical cell mitosis.
Yes, atypical cases, only for the malignant component.
That would not be required for a diagnosis of Leydig cell tumor.
But ma'am, reporting Leydig cell tumor in a 66-year-old female who is already into androgen insensitive syndrome, she has developed a hyperplasia of the Leydig cells over all these years. Maybe it was ignorance on the patient side that she had not reported it prior when she had a smaller mass. So we went more into favor of an hyperplasia over Leydig cell tumor. Yeah, I'll discuss about androgen insensitivity syndrome. It is a syndrome with karyotype of 46XY, where there is mutation in the AR gene. So it affects usually 2 to 5 per 1 lakh of population who is genetically male. The risk of gonadal neoplasms is higher in complete androgen insensitivity syndrome. The most common that are seen are carcinomas in situ, gonadoblastoma, Sertoli cell tumor, seminoma. In our case, this is the first case to be reported of complete androgen insensitivity syndrome with malignant phylloides with bilateral Leydig cell hyperplasia. As the literature says, there are gonadal neoplasms that have been observed in these patients. And in fact, this is the first case at this age, presenting at 66 years of age with this syndrome, who was not diagnosed earlier or probably who had not undergone any investigations. And the patient has developed malignant phylloids on the background of gynecomastia. Thank you. These are some of the references.